Hello everyone and welcome to Cardio Visual. I'm Matt Holden and here we're going to start a new series. I'm going to go over some real life patients I had as a paramedic and while I was in the hospital, and we'll break down some of their EKGs and run through these scenarios. So first off, we're going to start with a 67-year-old male with quote-unquote stroke-like symptoms per his wife. The patient is unresponsive initially but does open his eyes without following commands and is non-verbal. His eyes are darting back and forth, and he's not able to really look at you. He is pale and diaphoretic as well. I like to do something called the door test, which is where your initial thought on a patient categorizes them into sick or not sick, or stable versus unstable. He looks pretty sick to me, but we need to get some more information. His wife says his medical history includes hyperlipidemia, hypertension, and coronary artery disease. These are important risk factors to keep in mind. Based on this, he does have factors for a stroke or a heart issue. What else would you like to know? Well, obviously, we need to get some vitals on this guy. So here's his vitals. Blood pressure is pretty soft, 66/32, so he is hypotensive. Heart rate is thready and rapid. You can't really calculate a rate on it. Oxygen saturation 88% on room air, so he is hypoxic as well. BGL was 112, which is completely fine. And a patient who has had stroke-like symptoms and is pale and diaphoretic, always get a glucose on them to ensure they aren't hypoglycemic. Given that this patient has altered mental status, hypotension, and hypoxia, this patient is considered unstable. But why is he unstable, or why is he sick? We need to quickly identify the underlying cause, and the next step is going to be obtaining an EKG. Alrighty, so here is his EKG. Pause the video and determine what you think this rhythm is. So we see a wide, complex tachycardia around 175 beats per minute. This is going to be consistent with ventricular tachycardia, or VT. VTach is a life-threatening rhythm that requires immediate intervention, especially in unstable patients like this one. You can also see we have some right axis deviation because lead 1 is down and AVF is up. I have some arrows on what might be P waves signifying AV dissociation, but that is completely unclear. If you're ever unsure if there are P waves or flutter waves, you can do something called a Lewis lead in a stable patient. This patient is of course unstable, so no Lewis lead. But how do I know this is ventricular tachycardia? So let's break down what it means. Ventricular means the bottom part of our heart, which is our ventricles, and tachycardia means a fast heart rate, usually over 100 beats per minute. This rhythm is originating in the ventricles and is very fast. I prefer to use a cutoff about 120-130 beats per minute when trying to discern between ventricular tachycardia and something called accelerated idioventricular rhythm, or AIVR. The reason why is that AIVR is thought to be a reperfusion rhythm and is usually self-terminating, so no need to blunt the rhythm with treatments. Ventricular tachycardia, on the other hand, is deadly and you need to correct the rhythm. So a fast, wide, complex tachycardia with no PQRS, PQRS, PQRS is going to be ventricular tachycardia every day and twice on Sundays. Remember, for a QRS to be wide, it needs to be 120 milliseconds or more. Another small caveat I'd like to bring into this is if your QRS is over 1 big box wide or nearing 1 big box wide, start considering a tox or metabolic issue such as hyperkalemia, which can mimic ventricular tachycardia. So let's get into our treatments. So at this point, the patient is diagnosed with unstable VT. What do we do next? Well, we have two courses of action. You can do the medication route or the electrical route. In an unstable patient with ventricular tachycardia, the answer is synchronized cardioversion. Medications such as antiarrhythmics can be useful, but when a patient is hypotensive and showing signs of shock, we prioritize cardioversion. Remember this phrase, Edison before medicine. I'm a huge advocate for sedating patients in many scenarios, but if the patient is this sick, I would suggest that you don't give a benzodiazepine such as Versed prior to cardioversion, as you don't want to tank their blood pressure more and cause them to go into cardiac arrest. However, I will say that synchronized cardioverting a patient is not a fun experience. It is very painful for the patient, so you might need to give some medications afterwards to help deal with that pain. Now let's talk a little bit more about synchronized cardioverting. When you synchronize cardiovert someone, it is the same process as defibrillating a patient. However, you must make sure you hit the sync button to synchronize the monitor to the rhythm. A little tidbit of information here, because the monitor will shock a patient at a certain time when in sync mode, you might need to press and hold the shock button until it is delivered. So in this patient, we cardiovert the patient into a sinus rhythm. What would we do if he continues to go into VTAC? Well, you can keep cardioverting them if unstable. Another thing you can do is possibly administer amiodarone. Amiodarone is commonly used in treating VTAC, especially in stable VTAC patients. But to be honest, I can count on my one hand how many stable VTAC patients I've had. Not very common. Now that we've restored the patient to a sinus rhythm, our focus shifts to stabilizing the patient and preventing further episodes of VTAC. So now we get into the why this patient is having ventricular tachycardia. Given the patient's history of coronary artery disease, this episode of VT was likely caused due to a re-entry circuit around scar tissue. This is a common cause of VT in patients with myocardial damage, such as from a STEMI or ST elevation myocardial infarction. Our next steps will involve continuous monitoring, getting labs, and considering long-term interventions such as antiarrhythmics or an ICD to prevent future arrhythmic events. For me, I just brought him to the ER and they did all that work for me. In summary, this patient presented with unstable VTAC, which is a life-threatening arrhythmia. Our quick assessment, EKG interpretation, and immediate synchronized cardioversion were key to restoring the stability of the patient. Always remember to prioritize cardioversion in unstable VTAC cases. And remember, any wide complex tachycardia that's not over one big box wide, with no PQRS, 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 is going to be ventricular tachycardia. Thank you so much for watching. If you found this case helpful, don't forget to leave a like, subscribe, and share this video with some of your colleagues who might be struggling with EKGs. Stay tuned for more critical case studies and EKG interpretation tips. See you guys at the next video, and you guys have a great one.